I'm going to quickly go through the management of hypoxemic respiratory failure non-invasively, at least not intubated. This is really a primer for patients that are coming to an ICU short of being intubated, which may be a reality for an entire unit soon enough, I think, as our numbers get bigger. I think this is a common face of SARS-CoV-2. This is the one I think that's on the front page of CNN. But for us in the ICU, what we see in critically ill COVID patients is hypoxemia. I mean, that's the marked feature. I mean, most people don't get this where maybe anywhere from 5 to 10% of people end up in the ICU. For the remainder of people, it's about cough and fever, maybe some more milder symptoms, some people that make it into the hospital with viral illness. But the reason that they come to us is predominantly because of hypoxemia. There are a few people that come because they have other medical problems and happen to have COVID, but they're coming to the ICU very frequently because of hypoxemia. And this is how they look when they're really ill. They either have non-rebreathe or high-flow nasal cannula, which we'll talk about. Notice the lack of PPE. This clearly isn't a COVID patient. Or they're having some tummy time, which we'll talk about in a little bit as well. And this is what we're trying to avoid. The cost of invasive mechanical ventilation is high, and I'll go over that in a little bit over the next few slides. But we're trying to, what we're going to try to talk about are strategies to maximize the non-invasive mechanical ventilation approach to these patients and minimize the amount of time that, or the frequency that they get on invasive mechanical ventilation. Starting early last month, reports out of China suggested, again, maybe 5 to 10% of people that were infected with COVID would require an ICU, and that case fatality wasn't very clear at that time. But early reports out of the one province in China suggested that up to 88% of people that got on the ventilator died, which was alarming. And early on, we were kind of talking about this as being ARDS, and quite honestly, I don't think it is. You know, just last week, Dr. Schmidt from Iowa, who I consider one of the smarter people in our field, kind of defended the point that this is ARDS and really kind of suggested that we shouldn't be managing it differently from ARDS. But I think that there's enough experience that, I don't know, it just, not to naysay someone who clearly is smarter and brighter and has thought about things a lot, but, you know, it just seems that there seems to be a lot about this that is not ARDS. The European Society of Critical Care Medicine video, which I've shared before, and then a video that I put together for anesthesia that follows those same themes, kind of goes into at least some cases that really don't act like ARDS, and using strategies on the vent, such as higher PEEP, may be one of the reasons that there is such a high mortality. And the reason we should try to avoid, since we really don't know what we're doing when people get on the vent, avoid getting to that position when we're on the vent. More recent data, Italy, it reported a large group of patients that required invasive mechanical ventilation, and they reported a low number of low mortality. But this number is a little bit artifactual. They were reporting 26% of the entire 1150 patients that required mechanical ventilation in this study. That's who they had complete data on. But at the time of publication, more than 50% of that group still was in the ICU. So it's really this. I think this mortality number is kind of artifactual and using a denominator that of the 1150 that just doesn't work very well. And so this mortality is going to be higher. Over half of those patients, half of those 18 patients in those 3 Seattle hospitals died. And of the remaining people in the hospital, of the 7 remaining people, 3 of them were on ventilators. So this is, this may end up being higher than 50%. And then a really scary set of numbers came out this week, just a few days ago, in JAMA, released, the scary piece of data that came out in New York just a few days ago. Out of 5,700 people, of which the denominator is correct here. They're looking at the 2,634 that they have data through discharge or death. Of that number, so now they're using a better, more accurate denominator, 15% of hospitalized patients needed the ICU. Most of those required invasive mechanical ventilation, which may mean that their threshold for intubation was very low because, again, most of that 14.2% required invasive mechanical ventilation, and of that, 88% died. Which is just really scary. They don't have a lot of information about median PF scores or how severe the hypoxemia is or strategies that they were using to determine when to put people on the vent. But, and they certainly are resource limited and stressed, and it's New York. I don't know what that means, but all of that is contributes to this number that's amazing. But I tell you all that just to, again, kind of focus on what the point is today, which is how can we maximize therapy in the ICU hypoxemic patient short of invasive mechanical ventilation. This is the only slide that I have that's on semantics. We often talk about hypoxemia and hypoxia. When we're talking about low saturations or low oxygen tensions, that's hypoxemia. Hypoxia is a condition or a state. It is when people have stroke-like symptoms or chest pain symptoms or evidence of end organ dysfunction, but that is hypoxia. But when we're talking about measuring low oxygen, either with an oxygen tension or saturation, that's hypoxemia. So, as promised and as probably Amarin dreads, I am going to talk a little bit about the math of hypoxemia, and not for too long. I kind of really cut this part short, but I do want to kind of go into the mechanisms of hypoxemia in COVID-19 because that leads to naturally potential treatment and abatement strategies. Inspired oxygen in the air around us is at 160 torr. In the trachea, that's 150 torr. Our resting alveolar tension, if we're normal and at sea level, is about 100 millimeters of mercury. Not torr, sorry, this is all millimeters of mercury. And that means that our arterial oxygen with a small gradient between alveolar tension and arterial tension is single digits. I didn't go too much into the math of that, but again, oxygen tensions at the alveolar and the arterial level are very close with a small AA gradient, and then after offloading in the periphery, oxygen tensions are lower, usually in the range of 40 millimeters of mercury, which is 75% saturation. Again, the primary thing that determines content, as I'll get into in a second, is not millimeters of mercury, but saturation, which is why it should always be reported on an ABG. Again, at the arterial and alveolar and the capillary level, millimeters of mercury are in the high 90s, therefore correlating with near 100% saturation. And after 25% of that is offloaded to the tissues at saturations of 75% on the venous side, we're at 40 millimeters of mercury. So what causes hypoxemia in all patients? I mean, these are the 5 or 6 causes. Really, we're going to focus on shunt and VQ imbalance in this case. Those are the primary causes of hypoxemia in most inpatients. We're not practicing at altitude and only rarely take care of people that have overdosed to the point they're hypoventilating. And we do take care of a good number of people with hepatopulmonary syndrome. But for this disorder, we're going to focus on shunt and VQ imbalance. And they're not different things. The way that Dr. West describes it is that they are part of a spectrum. Shown on the far left of this screen is blood passing by a alveolus that's not participating in gas exchange. Hence, blood is shunting past this alveolus. VQ imbalance can be both low or high. In this case, there's areas of low ventilation because of airway disease that limits airway ventilation with normal perfusion. So in this case, the quotient of ventilation to perfusion is low. And in this case, where ventilation isn't immediately abnormal, there is low perfusion from intravascular pathology. The classic example of this is pulmonary embolism, which I'll come back to. And we've talked a lot about this week, I know, in terms of anticoagulation, but I'll just comment on this at the end as well. But this would be high VQ balance. Again, in this case, I mean, this can all be considered part of a VQ spectrum. Because there's no ventilation and there is perfusion, this ratio is 0. In this case, again, low ventilation with normal perfusion is greater than 0, but less than matched. In this case, normal people, most of us, hopefully, have close to 1 value for our VQ balance. And in this case, because there is no perfusion or little perfusion in these areas, the denominator is small and the VQ balance is high. In both shunt and VQ mismatch can lead to significant hypoxemia. And I'll just take a few seconds to go through the physiology of shunt and how it's apparently different than VQ imbalance and how we know that at the bedside. And this is really for the residents, trainees that might view this. If normal alveolar tension is 100 millimeters of mercury and there's a narrow AA gradient, what is the alveolar tension in this shunted, collapsed alveolus? Well, it's not getting oxygen from the airway. So in this case, it gets oxygen from similar substance around it, which is the fluid-filled material that's passing by it, which is the oxygen tension of mixed venous blood. Because this vessel doesn't have gas onloading or offloading, this oxygen tension passes on through the pulmonary circuit without any increase in oxygen tension. In this case, half the blood has a normal oxygen tension and half the blood has a low oxygen tension. And it may be, you may be tempted to think that the arterial tension is going to be the average of these two. But that gets to what really determines the content of oxygen in the blood. It isn't oxygen tension. The way that oxygen is carried, so this, the arterial tension isn't going to be 60-some millimeters of mercury. We have to remember that oxygen is carried saturated to hemoglobin. That's where almost all of the oxygen is in the blood, bound chemically to hemoglobin. And again, it goes back to that tension saturation curve that I've showed once before. And because saturation and how the hemoglobin concentration are the primary determinants of content is, again, largely related to saturation. Only a little bit of the content of arterial blood is due to direct dissolution of oxygen into the serum of the blood. So you can see that while the solid line here is the content of oxygen bound to hemoglobin, only a little bit more oxygen is carried in the blood as oxygen, as you increase oxygen tensions by adding supplemental oxygen by that amount that is directly dissolved in the blood. Some important numbers to remember in terms of tension and saturation. Anytime that you have tensions over 90, you should be in hemoglobin saturations in the high 90s. 60 works out to be about 90%. We usually say 55 is 88%. Again, we've talked about how venous tensions are usually 75%, and 27% is about, 27 millimeters of mercury is about 50% saturated. So if we go back to this example, where the half the blood has a tension of 27 and half the blood has a tension of 98, the saturations that coincide with that are half the blood is 100% saturated and half the blood is 50% saturated, resulting in the aggregate amount of blood when mixed being 75% saturated, and therefore having an oxygen tension of about 40 millimeters of mercury. So this is now someone that has arterial tensions that are more like normal venous tensions in normal people. So if we give this patient with significant shunt, this is actually a 50% shunt, 100% oxygen, we can rise the normal alveolar tensions close to 700 millimeters of mercury. But because, again, the airways don't contribute to oxygenation of this alveolus because this is a fluid-filled structure, half the blood will still remain 50% saturated, and it's hard to go above 100%. Now on this side you might have a little bit more content, again, because of that dissolved amount of oxygen, but you can't get higher than 100% saturation of the hemoglobin that's passing through here, and hence saturation doesn't change significantly, and therefore tension doesn't change significantly even with 100% blood. This is mathematically why we say that shunt does not respond to oxygen. Conversely, VQ mismatch, and this is a low VQ setting, just to make the math work out properly, I just made the assumption that only alveolar tension of 27 was possible with this degree of decreased ventilation, so that therefore this patient would again be 75% saturated. If you give this patient just a minimal amount of supplemental oxygen, you can, so if you double the amount of oxygen, you may be able to double the alveolar tension on this side, as you would on this side as well. Now you have, with a significant, with a minimal AA gradient, increased this side's hemoglobin saturation considerably, and then the mixing of equal portions of blood results in a very easily correctable arterial saturation and correction of hypoxemia. That's it for the math. Again, shunt, very little improvement, all related to potentially with 100% oxygen, all related to just increased dissolution of oxygen into the serum, not onto hemoglobin, and very minimal supplemental oxygen improving VQ mismatch. And again, shunt does not normalize with supplemental oxygen. The rest of this story I'll do with the interns in a couple of months, but has to do with the determinants of delivery and oxygen consumption. But again, that's it for the math. So going to the clinical scenario, this is what we may see. In the pre-COVID era, in 2019 and before, any 60-year-old nursing home resident that came in with this chest x-ray, we would say has aspiration of pneumonia and clearly needs to come to the ICU for intubation. Nowadays, I'll tell you specifically last night, any nursing home resident that comes in with this chest x-ray is COVID until proven otherwise and needs 3 negative tests and probably ID to bless them to say that they don't have COVID. Now, technically the typical x-ray looks more patchy and heterogeneous, but we have seen a significant number of people that have this diffuse type of process, and even though it looks diffuse on chest x-ray, it can be quite heterogeneous on CT scan. We've only gotten a few CT scans. And this pattern is diffuse alveolar damage. This is alveoli with type 2 cell hyperplasia, some hyaline membranes within the alveolar spaces, and some mild interstitial inflammation. So in the current era, the first step in treating someone that comes in hypoxemic, 75% saturated with a significant shunt and some VQ imbalance is to try supplemental oxygen. And simple supplemental oxygen comes in the form of nasal cannula oxygen up to 6 to 8 liters, and face mask non-rebreathers up to 15 liters per minute. We're not cheap with the oxygen that comes out of the walls. Every liter per minute flow that comes out of the walls is actually 100% saturated. We talk about how each liter per minute adds 3 or 4% per liter to the FiO2, but that's because due to its low flow rate, as we breathe it in, we're entraining room air around it. So there's a significant admixture with ambient air. And this is even more true in people that have respiratory pathology. The more respiratory distress you have, the more you're nasal flaring and drawing in air in addition to oxygen through around the nasal cannula, or your mouth breathing and drawing in more air. Said another way, tracheal FiO2s on 100% non-rebreather can be as low as 40 or 50%, because in the distressed patient, that entrainment of room air, also that inconsistency of keeping oxygen apparatus in the nose and mouth leads to lower tracheal oxygen concentrations. But any of you normal breathers, if you just take 4 or 6 liters of nasal cannula and you closed your mouth and you pinched your nose, could easily get tracheal FiO2s to double that of the distressed patient on a non-rebreather. Because again, that oxygen that's coming out of the wall is 100%, and if you are able to not entrain air, you can get tracheal oxygen concentrations to be quite high. At the end of the day, though, these things fail in significant COVID pneumonia because, again, shunt does not normalize with supplemental oxygen, even if you were able to get tracheal FiO2 up to 100%. Again, largely because of entrainment, but also mostly because a good portion of this is not VQ imbalance, it is shunt. So the next step, and probably the main tool that's being used not just here but around the world for patients with significant severe hypoxemia with their COVID pneumonia, is high-flow nasal cannula, given always heated and humidified. And there's plenty of data that goes into the evidence and the physiology, and I'm just going to review a little bit of this. This is not the machine that we use. I'll show you the 2 different types of high-flow nasal cannula that we have. But the benefits of this is, again, in that patient that's distressed, that has that high inspiratory effort, matching their inspiratory airflow with high applied airflow at the nose can minimize some of that entrainment. It's been shown with tracheal catheters that you can actually generate a certain amount of positive pressure equivalent to 2 to 4 centimeters of PEEP depending on the flow rate. So you're giving a little bit of PEEP despite having a non-invasive approach. There's some evidence that heated humidified air improves mucociliary function and helps with clearance. And also by washing out the nasopharyngeal space of CO2, there's less anatomic dead space. And that may help with oxygenation and ventilation. And another thing kind of related to that PEEP, which not only increases end expiratory lung volume, it also will stent open airways. This may be particularly important in COVID. I didn't really go into this significantly, but what we are noticing on the vent is that patients with COVID pneumonia do have upper airways resistance more than would be predicted by their pre-existing smoking history or any history of reactive airways processes. So having a little bit of positive pressure in those upper airways and opening them up decreases the resistive work of breathing. And so these are all potential benefits from high-flow nasal cannula. So I'll go into how we set it up, but the issue that we're seeing is that clearly, and people in New York are facing, is that this doesn't work, and patients still need to go on to invasive mechanical ventilation. So what are ways to predict when to go forward with going ahead and intubating the patient? We honestly, let me see, did I show you I guess I didn't include the pictures of our systems. Hopefully I have it somewhere in there. We have an OptiFlowSieve system and we have a Vapotherm system. I thought I included pictures. Oh, they're coming up. So when do we know when to go ahead and intubate these patients? This is extremely tricky. There have been some validated or recently validated ROX index, which is just taking the saturation based on the pulse ox over the FiO2 in a fraction. So for instance, if you're 88% saturated or 80% saturated, we'll make it easy, 90% saturated with an FiO2 of 45%, that would be a ROX index of 2. So the higher that is, the better you are. And if you have a ROX index of approaching 5 over that first 12 hours, there's a lower risk of intubation. And you can see if those values are low at 2, 6, and 12 hours, those are predictors of the patients needing to be intubated. The issue that we have in these patients, though, is these patients have a high respiratory rate and seem very comfortable. So using just respiratory rate to predict whether they need invasive mechanical ventilation is not very useful. And again, in this group of patients, we're noticing that mortality is so high. So the cost of committing someone to mechanical ventilation, really has to be kind of balanced with trying additional methods. And we'll go through some additional ancillary methods in a second. But usually when we're getting to 60 liters of flow or at 100% and patients aren't improving and they have a really low PaO2 and PF ratios, the right thing is usually to consider intubation in those patients. So proven benefits of high-flow nasal cannula. Well, the largest proven benefit is in this group of patients with acute hypoxemic respiratory failure. The Florali trial is a large 300-patient randomized controlled trial now published almost 5 years ago, randomizing patients to high-flow nasal cannula, non-invasive ventilation versus a face mask oxygen. And the group that did the best was high-flow nasal cannula. There are some criticisms of this study in terms of did the non-invasive group get adequately treated with adequate doses of non-invasive ventilation and other things about the protocol itself. But this, along with other studies in hypoxemic respiratory failure and early ARDS, in meta-analysis and in aggregate form, seem to suggest that there is at least a non-inferiority, if not a clear benefit, to high-flow nasal cannula early in severe hypoxemic respiratory failure. Whether it's useful after extubation to prevent reintubation is still kind of unclear. It's probably not true in abdominal surgery, but has shown more promise in cardiovascular surgery. But it's certainly not inferior to non-invasive ventilation for avoiding reintubation. There are some obvious mechanistic ways that it's better in the immunocompromised patient just because the cost of being on the ventilator and the risk of ventilator-associated pneumonia being so high in that group. In truth, limited data has kind of shown arguable benefit and potential risk of high flow in some immunocompromised groups. The PEEP is helpful in obese patients, and there's even cost analysis benefit in using this at end of life to mitigate some of the air hunger seen in palliative algorithms using high-flow nasal cannula. So the two things that we use, again, are the OptiFlow shown here with the vent that we use. We use the Maquette Servo Use. So you can use the OptiFlow through its own proprietary kind of device like the Vapotherm here, but it can also be, the apparatus can be rigged through the ventilator. And this is beneficial for a number of reasons. One, nebulized therapies can be given in line with this with an expiratory filter, so there's less aerosolization of nebulized therapies. And number two, the ventilator is in the room so that if and when an endotracheal tube is needed, the ventilator is readily available and doesn't delay anything. Again, flows can be titrated up to 60 liters per minute. I'll come back and talk about the choice of initial flow rate. And the oxygen can be titrated up to an FiO2 of 100%. Shown here is a 25-liter flow rate and 40%. The Vapotherm can't be given through a vent as far as I know. It's given through this type of device. The heated humidity, this is the temperature of the air going through the system. This is the flow rate, and this is the FiO2. It's a little bit different because the flow can only be titrated up to 40 liters per minute. We have not, I think last night was the first time I saw someone on the Vapotherm system. I don't know. I have no financial disclosures. I certainly don't make any money. So but the Vapotherm, the people that discuss the benefit of the Vapotherm, the company suggests that the flow rate can be truncated to 40 liters because the cannula itself is a little bit shorter and cut off, and they describe this kind of pinched hose effect of having a shorter cannula, which, again, I don't fully believe because flow rates are flow rates. So, but apparently 40 liters per minute on the Vapotherm, per the company's report, is similar to 60 liters per minute on other high-flow systems. Again, for the most part, we have been using the OptiFlow, but and I'm not sure, and I have not heard of any potential shortages. So if this fails, what other non-invasive methods do we have? Again, this is the most common thing that we're using. Sometimes we're starting at 40 liters, but if we're trying to match patient effort, if they're having significant air hunger and dyspnea, we are going up to 60 liters. We initially we had started at lower flow rates, and I'll kind of come back to aerosol dispersion, but we were worried about infectivity to healthcare workers. But there really is no harm compared to other ways of giving oxygen, of taking the flow all the way up to the maximums of these high-flow systems. And I'll show you some data to support that in a second. But if this fails, really, we're going to intubation. But to just discuss non-invasive positive pressure ventilation, or so-called BiPAP, it certainly is beneficial. There are lots of reports around the world that non-invasive ventilation is helping patients with air hunger, hypoxemia. The more assured PEEP given by the tight interface improves the shunt and opens up airways, so that you certainly can imagine both VQ matching that occurs with pneumonia and shunt that occurs with pneumonia can be reduced using non-invasive ventilation. And again, case reports and series and colleagues all tell us that they are successfully using BiPAP and CPAP, and it certainly does decrease workup breathing. Here are some of the issues with using non-invasive ventilation. This is not like heart failure or an asthma exacerbation that temporally can be quickly reversed. Because we're dealing with patients that have protracted severe hypoxemic respiratory failure measured in days to week plus, having that tight-fitting mask is onerous. Patients will frequently remove the mask, move the mask, and lateralizing the mask has been shown to drastically increase dispersion distance of droplets. There is limited retrospective data. This logistic regression analysis in clinical infectious disease that suggested that non-invasive ventilation in SARS-CoV-1 may have been an independent risk factor. At least there's an association with dissemination of SARS in local areas, in particular to healthcare workers. And again, especially if you're giving non-invasive ventilation not with one of our full vents, but with a single-limbed inspiratory vent with an open expiratory port, then you can get dispersion that goes as far as 1 meter in some models. So let's just talk about dispersion of droplets with the different ways that we've talked about giving oxygen. And I'm sorry I didn't include the references here. These are data that have come out in the last 4 or 5 years. The distance that dispersion droplets have been modeled and measured with simple nasal cannula at flow rates up to, standard flow rates up to 5 liters is up to close to ½ meter. Face mask oxygen, despite it being at a higher flow rate because of its physical barrier, the dispersion rate is similar, if not maybe a little bit smaller. It's on the same order as nasal cannula. Interestingly, even though the flow is so much higher in high-flow nasal cannula, the dispersion of particles is much less. And I guess that kind of makes sense just because the direction of the flow is counter to the dispersion of the infected droplets. And interestingly, that distance decreases as the patient's severity of hypoxemia gets worse. So, that being said, if the high-flow nasal cannula prongs are loose or lateralized on the patient's nose, that dispersion can be of patient droplets can be significantly further than nasal cannula, which is why we wear a mask. We have patients wear a mask over their high-flow nasal cannula. In modeling of CPAP, when you're using a full oronasal mask with no leak, and again, this is modeling. The data from this is just based on modeling. There's minimal dispersion distance. If you're just using nasal prongs for CPAP, you actually are getting dispersion that models to be twice the distance of the high flow. The problem again with BiPAP though is that while it is physiologically and clinically been shown to be beneficial in patients that need to wear it continuously for 4 to 7 days, they often remove the mask. So our mainstay has been going to high-flow nasal cannula and covering it. Now, what the manufacturer recommends is using a surgical mask so that if the prongs get lateralized, that dispersion distance can be mitigated to some degree. What we've been doing, sorry about that, what we've been doing is covering the high-flow nasal cannula with a tight-fitting non-rebreather. That way, if they are entraining any surrounding gas mixture, they're getting at least a gas mixture that's oxygen-rich while providing that barrier for minimizing dispersion. So we haven't adopted non-invasive yet, and I think that there may be exceptions, and we may use it in some cases for oxygenation that we think is temporary. But if you remember the evidence for high-flow nasal cannula versus non-invasive ventilation in acute hypoxemic respiratory failure, again, favors the use of high-flow nasal cannula. So if you're failing to get results with high-flow nasal cannula, it's hard to imagine that adding non-invasive would be that beneficial. Additionally, based on the evidence available, the WHO lists non-invasive ventilation, both bilevel and CPAP, as one of the high-risk aerosolization procedures for healthcare workers, and the references there on the bottom. This includes procedures like bronchoscopy, chest physiotherapy. So the WHO, based on the SARS experience, does consider non-invasive and CPAP a high-risk aerosolizing procedure. Again, perfectly modeled in patients that don't remove the mask, and you have a total nose and mouth mask, the dispersion is very low, but in real-world practice, we worry about it. What we really don't know what to do, and last night we brought someone over from the floor because they needed bilevel ventilation, is what to do when someone is really suffering without their home CPAP and home BiPAP. What the UK has kind of said is don't bring your home device with you because the heated humidified is probably full of COVID, and that's going to really increase your dispersion. Try to avoid it as much as possible. And if we do it, we're doing it in the ICU with a ICU vent. The ICU vents have both an inspiratory and an expiratory limb, so-called double limb, and the expiratory limb can be can have an expiratory filter. And when people are sleeping with their non-invasive, I think we need to be, we haven't had a lot of experience with this, we need to have a way of minimizing how much healthcare workers are doing inside of the room. I want to show you this, but tell you immediately that it's not available in the U.S. The Italians and other Europeans are using this type of helmet, non-invasive, that the group out of Chicago showed to be beneficial for ARDS 4 years ago. It's just not FDA approved here, so I'm just going to keep going to the last topic, which is adjunctive therapies. So we've talked about oxygen therapies and why they work for VQ matching or low VQ, may not work for shunt. One way to help with the shunt fraction is to minimize the amount of additional alveolar flooding. So as much as possible, as renal function permits, avoid fluid loading and try to diurese. That's one of the mainstays of non-oxygen therapy in these non-intubated patients and intubated patients. Prone positioning, I'll talk about a little bit on the next slide, certainly has been a very popular topic in the non-intubated and the intubated group. I'll touch a little bit about Flolan, and I know that a very popular topic right now is anticoagulation. I'll just touch on it a little bit, and steroids. So prone positioning first, colloquially called tummy time. Groups are really pushing having patients stay on their belly. We had a transfer last night from Sibley that refused to get off of his belly. And I think that this all comes from the lay press and how information gets disseminated to the public. We had another family member or a power of attorney for a patient demand that we start putting this very fragile patient on their tummy over this last weekend. So this has become very popular, and I think most people on the call have probably seen those slides and images of people in New York that are on their cell phones on their tummy, on their belly, prone. Quite honestly, I don't know if it's any better than frequent incentive spirometry, getting out of bed to chair and ambulating. This is the pulmonary toilet that pulmonologists and hospitalists and medicine folk have been advocating for centuries. There is no study that compares self-proning with any of these other things. So I think any of the things listed here are adequate. What we're trying to do is just kind of minimize some of that atelectasis that develops. There is some interesting and esoteric data about high-flow nasal cannula and how it may actually be worse in the prone position that has to do with dorsal ventilation. But truthfully, anecdotally, in the last several weeks, people on high-flow nasal cannula on their tummy have improved in terms of their oxygenation, so I don't even think it's worth discussing. But I think anything that we can do to encourage minimizing atelectasis is important. I'm not going to talk much about this, but it did hit our front page yesterday, and it's hit many front pages around the country. But there is a considerable amount of evidence that there is some form of clotting, whether it's true thrombus, whether it's endothelial injury or endothelial damage, whether the patient's actually coagulopathic, and how much of this is truly macrothrombus. There are just case reports after case reports, but not a lot of evidence. Remember, besides having low VQ, one of the other ways that hypoxemia may present is with that high VQ, the prototypical example being this pulmonary embolism. As mentioned, it went online 2 days ago and then was on the bottom of the front page of the Washington Post yesterday. This was started off with experiences out of Emory, but this was in our drag. And so what are we doing? Really, we haven't really had a concerted plan until this last few days, and there has been a MedStar-wide practice guidance group specifically looking at different strategies of anticoagulating in the ICU. I think on the call that you all put on the other day, I expressed some of our frustrations, personal frustration with knowing that people weren't getting better and that they had high dead space and had potential for clot and not knowing what to do in terms of anticoagulation. I'm not going to share with you the near final format of the MedStar-wide practice suggestion for ICUs because it's not finalized, and it's just going to be a disservice. But I think by Monday or Tuesday, hopefully, it'll be out there. But at least for those patients that are considered low risk, everyone should be on at least prophylactic doses of anticoagulation, ideally low molecular weight heparin if possible to minimize entry into the room. But those people with clear and obvious macrothrombus or high risk for for pulmonary embolism, DVT, we should consider fully anticoagulating if that means they're continuously clotting off their renal catheters, or if they clearly have a high dead space, RV strain. I shared a alarming story with Dr. Fisher the other day that we saw RV enlargement. We had a relatively clear chest x-ray. There was no clots in the legs on our exam, and we pushed for a CT scan given the risk-benefit and didn't find a PE. And that patient, we didn't know what to do with anticoagulation, and then he started clotting off his dialysis line, so we did full anticoagulation. I think the unknown group, and this is clearly not based on any evidence, but largely because most other major medical centers are doing this, most major ICUs are doing this, is coming up with some guidance on an intermediate risk group that gets a little bit more than prophylaxis and not quite full anticoagulation. A lot of people are using D-dimer as part of it. We recognize and have been guided by our hematology colleagues that D-dimer, the meaning of it is really unknown in this disease or any inflammatory condition, but using that along with other clinical clues to come up with an intermediate group and a strategy for how to treat them. And so I'll just say more to come on this come Monday or Tuesday. Inhaled therapies. So we are using prostaglandin analog called Flolan, epoprostenol. It's actually a variant of it that's stabilized, so it's called Velitri, but it's Flolan essentially. And because we're giving it inhaled in patients that have significant shunt, it should have a salutary effect on normal alveolar and vessel groups, so that you have vasodilation to areas that are participating in gas exchange, and then a 50% shunt goes to a 25% shunt or a smaller shunt because more blood is now going past this area. Also, there's a much more complex story about how flow rates with high-flow nasal cannula interact with the Flolan, and I have to tell you, again, based on small numbers, I haven't been really impressed with oxygen improvement using inhaled Flolan with the high-flow nasal cannula, and it may be because we're using too high a flow rate when we're doing it. So we're going to relook at this, and a little bit more to come on this as well, but it's worth giving a shot in some patients to see whether we can get a buffer and allow some convalescing time before patients need mechanical ventilation, which again I started off by describing how high the cost is of mechanical ventilation. And then lastly, Steroids. This is, especially if it's more ARDS than it is focal pneumonia, especially if there's high inflammatory markers and cytokine activation, if the patient doesn't have significant neuroendocrine contraindications to steroids, then doing a moderate dose of steroids is something that can be considered. Certainly there are pitfalls to this, including the experience with SARS-CoV-1 and delayed viral clearance. And the evidence, quite honestly, is minimal and poor and weak, but I will be the first to admit I've given steroids when all else has failed with someone that seems to be going into cytokine activation syndrome and doesn't quite meet criteria for TOSI, and I don't even know what criteria for TOSI is. But consideration for steroids and in those situations as shown here. So in summary, this is just a recap on our written protocol for hypoxemia, which gets updated regularly. It needs to be updated again. But on the floor, you all know the kind of cutoffs to at least get a CCR evaluation when nasal cannula starts to increase considerably or you're getting to 6 liters or more, then we should be involved in this. And once they start to get into significant hypoxemia, the things that we talk about are the non-rebreather. We're avoiding non-invasive ventilation at the moment. We're avoiding chest PT. If we're doing nebulized therapies, we're stopping them and doing them as meter dose inhalers via the vent. The high flow nasal cannula can be attached to the vent. We used to be starting at flow rates that were much lower, but again, the real benefit of high flow nasal cannula is to match patient effort. So we're finding that starting at something between 30 and 40 and going up to 60, which is the max in terms of the flow rate, is appropriate, especially since it doesn't seem to increase aerosol dispersion significantly, and the amount of aerosol dispersion is still less than other modalities of oxygen delivery. And then the question that is the million-dollar question, which is when should we intubate? Again, given the high mortality cost in these patients, trying as much as possible with diuresis and high flow nasal cannula, while patients just get better by themselves or with whatever other therapies we may be giving. And of course, not waiting too late. What we're doing is having regular discussions with anesthesia colleagues at the end of the day about people that look like they may be tiring or have been on high amounts of high flow nasal cannula. That's something that we should be doing. Easy enough to call 405 tube. They love that discussion. Those people, the experience out of China has been those people that are on high flow nasal cannula and have really low PF ratios are the ones that usually proceed to intubation. And I spelled do wrong. And we all have kind of been practicing on the right way to intubate these patients, and now anesthesia are the ones that are doing it entirely. And so in summary, we kind of talk about the major issues here. This is not ARDS, despite what Dr. Schmidt says. The shunt and VQ imbalance are a big part of it. It's not just low VQ, though. It probably is some high VQ thrombus-related or endovascular damage-related cause of high VQ. High flow nasal cannula is the champion when people are coming into the ICU. We've had some good success. We're not sure who we should be using non-invasive, if anyone on, again, because of the risk of dislodgement and the duration that they need to be on it. And then the adjunctive therapies we kind of ran through: prone positioning, fluid management, steroids, more to come on anticoagulation, more to come on inhaled therapies, and then intubating, knowing that in many cases the battle is really lost, but we have had success extubating a group of patients so far. So I'll stop, and that leaves a few minutes for questions, hopefully.
We did have a question, with the reports being maybe there's not so many saddle emboli, but there's segmental emboli. Do you think there might be a role of dual energy CT to kind of see what the burden of peripheral thrombi might be?
Yeah, we've only done. I mean, I've only done one CT, the one I mentioned. The issues I kind of mentioned during your talk earlier in the week is one is the CT scanner has to be shut down for a while, but sometimes that has to happen. But I'll tell you, it was quite an effort to get that critically ill patient down to the scanner in the first place. This was someone that was intubated. This was someone that was very tenuous when they were moved. They were on pressors that and had some hemodynamic lability. So we often think about scanning as something that is, kind of like adding a proton pump inhibitor or something, and the nurses just do it. But as we all know, a road trip is probably one of the most scariest maneuvers that we do in an ICU when patients are critically ill. So, it took a lot of cajoling and hand-holding and travel with the patient to get this CT scan. And I wish that we could have a CT scanner more readily available like some people do right in the unit. So if anyone has any deep pockets, please put that as a project for the new hospital. But the road trips up and down the elevators are a place of potential significant danger to patient.
There's a couple other questions, but, I wanted to maybe focus a little bit on some nuts and bolts things today. And so, because I'm kind of hoping you can maybe help demystify high flow nasal cannula a little bit for people. Because, I think on the floor, let's say my nasal cannula, I can turn it up to 15 liters, right? So that's, and after 6 liters, it's not doing anything. So your nasal cannula, the high flow, what it accomplishes after that is predominantly humidification, right? And then of course the flow rates can go much, much higher. But really it's not so much the high flow cannula is the thing that is we should be worried about. It's just that it means it's a sicker patient. Or would you disagree with that?
Yeah, there's two things. The patient effort, like if you're just giving 15 liters and the patient's pulling, at a flow rate that's like 30, 40, 50 liters, then they're going to pull more than the oxygen provided by a simple nasal cannula device, and they entrain more air, so they just don't get adequate oxygenation. So the primary role of titrating up the high flow nasal cannula flow rate is to try to match patient effort. And the more that you're doing that, then the less ambient air entrainment. Now we're actually not allowing ambient air around the nasal cannula. Again, to minimize dispersion, we're covering the nasal cannula with oxygen-rich non-rebreather that's tightly fit. So that's part of it. And then the second part is the physical force of the flow at that high flow rate creates some beneficial effects of PEEP on both the airways and on opening up atelectatic lung areas. So there's the PEEP benefit to the airways, the PEEP benefit to atelectasis. The airways, by being stented open by this pressure, there's less work of breathing that the patient has to do, so they don't tire as easily. And then people have postulated that the heated, humidified air has some benefit to mucociliary function. Decreased.
Tell someone like me that if I'm managing it, when I'm titrating the flow rate, I'm watching the work of breathing, maybe predominantly.
Yeah, it's hard in these patients because of their neurotropism. They're often breathing very quickly, and so it's actually based on interview about how fatigued they feel, signs of fatigue, paradoxical abdominal motion. But really, we're also doing it to oxygen saturation. So when they start dropping from 96 to 95 to 94, we're going up from 30 liter flow, 40 liter flow, going up on the FiO2 as well. And then when we're at, if either the patient is clearly fatiguing, working hard, with or without blood gas evidence of respiratory, acidosis starting to build up, then or they're at high values of oxygen, then we'll intubate them.
And then just speaking of blood gases, what, besides for ventilator problems, what do you think that an ABG for our standpoint would offer in and above what a pulse oximeter can offer?
Yeah, it's a great question. You know, certainly the pulse ox has been pretty good for oxygenation and targeting that mid-90s is what we're doing. But in patients that are fatiguing, you know, that first blood gas that starts to look more 733 with PCO2s that are going into the 40s, but they're breathing fast. I mean, that's a sign that they're starting to fatigue. And then, of course, if you wait long enough, the true hypercapnia. You know, the blood gas is probably a late indicator, but it's challenging these patients again because they do have, especially when they're inflamed and febrile, they're tachypnic, and even sometimes when they're tachypnic and not febrile, they're actually quite comfortable talking in sentences. And you know, but when they're tiring, it's clear they're working hard. Their mental status is a little bit poor. They start to get paradoxical, and we should be, or their oxygen levels are just too high. But the blood gas helps with ventilatory failure.
Are you getting blood gases daily on these patients, or are you getting them more than daily, or just as you kind of clinically see them fatiguing and you start doing it?
Yeah, you know, the ones that are on high oxygen and/or pressors should be getting, you know, should have, you know, either an A line in, so that it, you know, so that we can monitor it, you know, per clinic, you know, for both blood draws for other things, but also to monitor blood gases a little bit more frequently. We don't have a necessary protocol, but I think if they're on 60 liters and pushing 80, 90, 100%, and we can't really, and they can't tell us that they're comfortable if they're altered for any reason, then we should be getting them several times a day or with any clinical change.
Is there a BMI that the high flow doesn't really offer the benefits that you're describing?
There's actually some evidence that it's, you know, in the obese population, it's a group of patients with potential benefit. We had someone leave the unit that I just noticed on C63 that was being, at least there was a discharge note being written that was quite large that did very well on high flow. You know, I don't have a BMI in mind. I think one of the issues is that some of these people with really high BMIs, they also have obesity hypoventilation syndrome. So at night when they sleep and they get a little hypoventilatory, then they drop their oxygen saturations at nighttime. So I've had a couple of those patients where, you know, you feel like they're doing okay during the day, and then they get intubated at night, and it's probably because of their obesity hypoventilation syndrome.
Let's say we get a patient stepped up that was on 6 liters and we're planning to start the high flow. What would you recommend the starting flow rate be?
Yeah, if they look fairly comfortable, you know, but it was just because of the threshold being reached. If they're relatively comfortable, I think it's reasonable to start with 40 liters and, you know, use something. You know, oftentimes it'll automatically be 100% FiO2 and then titrated down by the respiratory therapist to a target saturation that shouldn't be 98, 99, 100, nor should it be below, you know, 90 for any period of time. And then if they, based on their oxygen and their work of breathing, you can go from 40 to 60 liters. But there is no magical algorithm. It's really patient by patient on their comfort level. And, you know, if they are obese, maybe you know, give them a higher flow rate. Most people tolerate it pretty well. Even patients that are altered, they tolerate it definitely better than non-invasive ventilation.
Sounds like 40 to 60 to start, depending on what they're breathing, with 100% FiO2, and you titrate down then.
Yeah, I mean, the whole point is to just maximize it and give them as much time as possible that hopefully, I mean, it's not like anything we're doing, we're sure is reversing this process, but just trying to give them as much time to get better by themselves and let things ride their course while we're trying to diurese if at all possible. I think the people that we really have had poor outcomes on. I still think that a large number of them are the ones that have inability to regulate volume and or go into frank renal failure.
Have we been seeing here at Georgetown what's being described as these silent hypoxemics or the happy hypoxemics? And in those,
yeah, you know, I think that's part of this neurotropism, that like they don't really notice as much that they're working hard, and they may not notice that their oxygen saturations are a little bit low. You know, I saw that. I don't know that I've clinically I saw that description in the literature. I don't know that I've seen it as much. I certainly have seen people breathing quickly that don't notice that they're breathing quickly, and maybe that's part of this. I don't know.
And right now, what do you think are, you know, you presented how 80% on the ventilator in New York maybe were not making it. How's our success rate for extubation here?
Dr. Reed gave us some numbers. Unfortunately, our numbers are kind of with the wrong denominator. It's all the people that are in the, I mean, it's all the people that are in the ICU right now, but our numbers, we're looking good in terms of the mortality is 14%. Again, that's including all people that are still in the ICU. So it's really hard to know. I mean, we're just getting our first group of people through. And our mortality on the ventilator was nowhere close to 80%, and I think it was less than 50%. I want to say it's in the 40s. I just don't remember the number. May even been lower, but you know, I think it's just we have too many people that are still on the vent or in the ICU to have a good idea. But when Dr. Reed shared our numbers with MedStar, you know, I think a few people emailed me and were like, wow, your numbers are really good. But some of it is, again, the denominator, but some of it is that I think we have been doing well. I will tell you that I do worry that some of the recent transfers for this load management thing have given us might put us a little behind in terms of outcomes. Some of the people we got last night were doozies.
This is the last question we have here. Anything you want to say about TPA as salvage therapy for ARDS and COVID?
No, you know, like you know, there are these case reports. The one popular one is that you know, giving it, you know, for I don't know what indication. I think that I have learned so much more about D-dimer in the last several days, and I think that people with clear, discrepant chest X-rays, high markers of inflammation, and I think people that have like D-dimers that are 20 plus. You know, there are some people that are considering doing this and have done it. I've heard of this group of 4 that I think most people have, where one person died within a few days, one person left the ICU, and 2 remain on the vent. I'd be really cautious about TPA. I'm so squeamish as it is about anticoagulation, and I don't know what the right thing is, but I just feel like we should be doing something in between on many people, and I have been. In the last week, but without really any guidance. But none of us have guidance, but TPA is very scary to me. I mean, it's hard to do procedures. And what are we going to do if we have a complication? I think the only indication for TPA is the ones that we clearly have defined when you have identified that clot and they have either shock or they have, you know, evidence of submassive with poor features or high-risk PE.